It's really a pleasure to be here. This is the second, and I hope annual, Digital Quality Summit. It's really been a key cornerstone of our efforts to bring in a much greater community into the HL7 FHIR family. Part of the issue, which I think that was raised yesterday, and it's really pervasive, is how we're going to deal with health quality disparities. And one of them that really drives me and has done so for a long time has been the issue of how are we going to manage quality. One of the key elements in all this was the 1999 publication of To Err is Human. In that publication, they estimated that we clinicians kill 100,000 Americans a year. Everyone was appalled. How could the statisticians have goofed so badly? Okay, 10,000. 10,000 a year. I don't think it's getting any better. Let me tell you a brief tale of my personal experience. No, I'm not the patient, but I was the doctor. Jack was a remarkable young man. When I met him, I was an academic oncologist. Jack had complained of knee pain. You don't have to be a radiologist to imagine that everything above the joint there shouldn't belong. But his family doctor said that he hadn't seen the X-ray report. It hadn't, no one had called him about it. He didn't look at the films. This is the chest X-ray. When I saw Jack, that football-sized thing in the right lung doesn't belong. You don't have to know any pathology to know that something that's metastatic isn't good. We have the distinction of having medical errors be the third leading cause of death in the United States. Perhaps, if you believe the Harvard report from earlier this year, we're now up to 250,000 Americans die of avoidable medical errors. I think that it's our job to drive quality, and no better place than how we share information. And I think that the future of better quality lies in having information at the point of care when decisions are being made. HL7 has been making standards for 3.5 decades. Half of all the information in the world is shared by some flavor of the HL7 standards. The important thing is that the standards hadn't kept up with the emerging technologies upon which we had become so dependent, called the internet, Google. The idea that emerged from an effort that we had called the Fresh Look Task Force was FHIR. And in 8 short years, it has really become a byword for enabling interoperability. We're a long way off, but no one said I'm not buying an iPhone when the iPhone 1 came out because it doesn't do image stabilization. It doesn't automatically uplink everything to the cloud. In fact, there are a lot of things that FHIR can't do. And I'm coming to you to ask you to become part of the community that says this is what FHIR needs, and this is what's going to change the landscape. But it didn't happen overnight. 8 years has been a long journey. A lot of it was stimulated when the Jason Task Force reported out in the fall of 2014 that the future of interoperability lie in open APIs. And The Argonauts were formed one night shortly after that meeting with a mission of enabling FHIR's adoption and development. I think one of the key elements that speaks so highly of Argonauts' work is that in less than 4 years, the Argonaut implementation guide has been actually embedded into the operating system of the iPhone. Now more than 500 healthcare systems across the United States have piloted this ability to share clinical data across electronic health records from imaging centers and laboratories as well. But FHIR really goes beyond the technical requirements. I sat in on a number of presentations, and it's really exciting to see how ubiquitous the technology has become. I have no interest in going into it from here, except to say that we are moving toward a community in which we all need to contribute. One of the important contributions to make this viable is the community partnership we've had with Harvard and Boston Children's to do bulk data. So we don't have the simple peer-to-peer exchange of data, but we can exchange large amounts of data seamlessly through a secure system of authentication. But in fact, it's more than just sharing data. It's getting the ideas right. And for any of you who aren't math majors, I apologize. I'll explain this one later. Instead, what has emerged is a series of technical tour de force. My passion has been clinical decision support. The physician of yesterday who could recall all of the information needed to make a clinical decision was a prized commodity. Nowadays, it's virtually impossible. At the end of the decade, some estimates are that there will be 200 data elements necessary to make a decision. In addition, a lot of you have been involved in the Da Vinci project, which emerged only in the last year as an effort to link the payer community to a notion of driving value-based care. And part of the excitement is the trajectory of Da Vinci promises to be even greater. So again, an outreach to try to make this community contribute to all of the things that Da Vinci can be. One of our partners in this is the ONC P2 task force that's developing concepts and socializing them so the ubiquity of FHIR doesn't lead to the challenges of interoperability that we had with V2. It was a very democratic solution and it broke interoperability. Perhaps we'll have a solution to FHIR that doesn't do that. For those of you who have an opportunity to go to Madrid, I recommend you take a peek at this at the Prado. I usually sit there for an hour. This is about the resistance to Napoleon's invasion of Madrid in the early 19th century. There are more federal agencies that are now supporting FHIR development and implementation. I think for me, one of the more exciting ones is the VA Lighthouse Gateway. For about 6 months, they had denigrated not only the workload, the financing, they even took away the name. So Drew Mickelgard, who's leading that effort, told me yesterday that we've taken back the name, and this will now provide veterans and clinicians who care for them data in near real time. CDC has a significant effort. We saw a brilliant demonstration last month here in this venue that they called Death on FHIR, but it was about morbidity and mortality reporting, and they had a pilot of 5 states that were collaborating in this effort. Partnerships with the FDA to realize the vision of real-world data so we don't rely on the double-blind, placebo-controlled gold standard trials of which I participated and produced medications and devices that worked half the time. There are multiple organizations that are working to integrate genomic data within the clinical paradigm. I think it's important that it's not a freestanding concept of your genome or genetic data, but really becomes part of the decision tree, so that I would guess all of us in this room, regardless of age, size, ethnic background, and the like, would have the same starting dose of the same drug, which would perhaps work half the time. We've had an interesting partnership with the Translational Science Group. They would like to see a virtuous learning health system where not only does preclinical research inform patient care, but the patient care really drives back the decisions they make in the science community. Host of non-government agencies are participating, and one of the exciting ones is the Consortium for Agile Genomics. It's a partnership from a global standpoint, so that this is not a US-centric phenomenon. As is the Transcelerate project. Transcelerate is a pre-competitive environment where IT is shared amongst some of the 25 leading pharmaceutical and biotech companies to drive the integration of healthcare into the clinical research front. I don't know any of you who have a clinical experience, but the ventilator, the IV pump, and other things in the hospital are blinking 0, 0, just like the VCR of 30 years ago. And many of them don't integrate with a health IT system that's working in the hospital. And so being able to report that data, utilize it both for quality and decision-making is really critical. Last month, here in DC, we saw a meeting of some of the leading health cloud vendors. And they all promised and got up on stage. It was quite a photo op where they assured everyone that they would be sharing their data on the cloud and would be doing so with a FHIR API. And then lo and behold, we've had a couple demonstration projects. One came from Microsoft, where their Azure environment is now sharing data with other cloud systems through FHIR. And lastly, the ONC report. This heat map, no pun intended, well, maybe there was a pun intended. This heat map shows that throughout the country, there are perhaps 2/3 to 3/4 of the health systems in the United States have a FHIR API available to them, and perhaps somewhere north of 1/3 have it go live. So, look, to quote my colleague Ed Hammond, and I think we really have a future for driving care quality, and all of you will be part of it. So I applaud your efforts today and moving forward, and thank you very much.